So my friends, I'm going to give you my tips to understand this guideline, okay? So first of all, I will like to tell you that please forget the last version of the guideline, okay? Forget it at all. Why? Because in this guideline, they have changed everything. And this is because of the uh, release of the Saving Babies Life Bundle 3 in its third version, okay? So they have found that the correct management of the cases of the small for gestational age, okay, is going to affect the outcome for the baby or reduce the perinatal morbidity and mortality, okay? So they have now changed the risk assessment, okay, in this guideline. And also they have changed the definitions in the guideline. How they changed the definition? Yes. In the past, we used to say, according to the RCOG guideline, that all the cases, small babies, okay, so this is a small for gestational age baby, less than 10 centile, this is small for gestational age. No matter it's very small, less than the third centile, or the baby is having abnormal Doppler, right? But now it's very important to understand the difference between the definitions, and I can say that the definition is a side of exam question, okay, possible side of the exam question. So the common definition says what is appropriate for gestational age. Okay, appropriate for a gestational age, that's mean the baby is growing within the normal range according to the background group of this baby. So for example, that's why we say customized or individualized chart, right? So for example, baby comes from Chinese origin, so we will customize the baby grows on a specialist chart for Chinese babies and so on, right? So if I have here a chart, for example, okay, and I know that most of you understand this concept, okay, and this is the gestational age by weeks, okay, and here I have the estimated fetal weight on that chart, okay, and I have, okay, this is the, for example, this is the normal population, okay, so babies on the 90th centile, this is the higher the group, right? Or this is the maximum normal, and babies at the 10th centile, this is the lowest normal value, right? So when you have a baby estimated to be below the 10th centile, let's say that this is the 10th centile. So this baby, since it's below the 10th centile, is small or larger for gestational age. That's baby is small, okay? Baby more than 90 centile. So this is the 90 centile, okay? And I have a baby more than 90 centile. This baby is large, yes. Good, okay. In between, those are normal gross baby, range from 10 to 90. So I will call this group appropriate for gestational age. Sometimes you will see the abbreviation AGA, especially that they have used this in the algorithm. So it's AGA means appropriate for gestational age, okay? That's mean normal baby. Okay, so small for gestational age, this is baby less than the 10th centile. Fetal growth restriction. FGR now, okay, have a specific criteria, and it's either one of two. What are the two criteria? I will call this baby a fetal growth restriction or FGR baby if this baby is very small, less than third decentile. So this is the lowest. We have 10 fetuses, sorry, 100 fetuses. Okay, so this baby is from the smallest two of them, right? Less than 3. Okay? One of the smallest babies. This is a FGR baby. Or the baby is less than 10 centile, okay, with abnormal Doppler. So the Doppler is not good for this baby. And if the Doppler is not good, means the gross and the outcome is not good. Baby is not getting enough blood, simply, right? So I have either this or that. I will call it FGR. Okay. So how about the risk assessment? Risk assessment in the past, we used to have minor risk factor, major risk factor. Do you remember this? Do you remember this? No, I don't want you to remember this, okay? Forget it, okay? I don't want you to remember this, really, okay? Yes, Dr. Laila, I told you before we start to forget it, right? Okay, so we will forget it now. Shh. Okay, so now what we will have? What we will have now is either a low risk or a moderate risk or a high risk, okay? So low risk individual means a normal lady with no risk factors for a small for gestational age. And we give her the color green, okay? So this is a low risk. No risk factor. Okay. And we have another group or the second group, and we give them the color yellow, and we call them the moderate risk. Moderate risk of having small for gestational age and fetal growth restriction. And we look here to the factors that, you know, determine the moderate risk factor. You find it either it's obstetric or current risk factor. Obstetric is previous small for gestational age baby. So guys, according to the definition, previous small baby means baby less than 10 centile, right? So may I ask you, baby Doppler was normal or abnormal? What do you think? Normal, of course. That's why they call it small for gestational age. Or a previous stillbirth. Okay, so a baby previous fetal death, stillbirth, intrauterine fetal death, right? Yes, but the baby was AGA. What is the AGA? AGA, appropriate for gestational age, right? So the baby have a normal birth weight at the time, but died in utero for any reason. Okay, so that's we put here at moderate risk group. Okay, who else we will put on the moderate risk group? Is the current smoker, and this is any number of smoking. She smoked 1 cigarette per day. She smoked 100 cigarettes per day. Doesn't matter for me. She is in the moderate risk group. Okay. Drug misuse. Age 40 or more. BMI less than 18.5. And other features like eating disorders or bowel disorder causing weight loss. So not only the BMI, it's with also other features. Gastric bypass surgery. So a lot of women now, they have a gastric bypass surgery and they become pregnant. So we will put them on the moderate risk group. Okay. A previous preterm delivery or second trimester miscarriage due to a placental reason, placental mediated. Okay. So this lady, moderate risk group. Okay. High risk group. This is the third group of ladies. Okay. And the high risk group, they give her the color red, right? That's because it's a high risk. Okay, so high risk group with the color red, which women or conditions that we will call as a high risk. Let's have a look. Now, high risk is women with medical condition like chronic kidney disease, chronic hypertension, autoimmune disease like SLE or antiphospholipid, complex cardiac disease, or a woman had an obstetric history like previous FGR, or hypertensive disease in a previous pregnancy, or hypertensive disease in a previous pregnancy, considered as a high risk factor? Yes. Why? I'll tell you. That's because if the woman had a previous preeclampsia, for example, okay, that's mean she had a risk factor for abnormal placenta, right? She had a placental problems. So also placenta problems is associated with a small for gestational age. And if you look to the risk factor of small for gestational age, even the old one and the risk factors for the preeclampsia, you will find that there is overlap, of course. And there is a lot of studies that actually comparing or trying to find out the relationship between both of them. And it's a good relation, by the way. Or a previous small for gestational age stillbirth. So this is not baby died in utero with appropriate weight. No, this is a baby was small and died. So this is high risk. Okay? Or in the current pregnancy, we measured the PAPA, okay? The pregnancy associated plasma protein A, and we found that it's less than 50 centile. Is that a major risk factor or high risk factor for small for gestational age? Yes. Inhibin A in the second trimester is more than MOM, multiplies of that median. Okay? Right? Or the alpha fetoprotein, which is also another serum marker, okay? In the second trimester, if it is measured, like in the quadruple test, for example, and you find that it's more than 2 MOM or multiplies of the median. So high value of alpha fetoprotein, high value of inhibin A, or low values of the PABA, that's mean high risk of small for gestational age, or FGR. Echogenic bowel. It used to be a major risk factor and now still a high risk factor. Okay, so echogenic bowel with us. Significant bleeding, especially in the early pregnancy. So when I study antepartum hemorrhage, I will find that the cases with antepartum hemorrhage, if it is significant in the early pregnancy, can affect the growth of the baby or not. Yes, it can. So high risk factors in significant bleeding cases. Estimated fetal weight less than the 3rd centile. So yes, I am doing a scan, a gross scan, or even anomaly scan, and I found that the baby is less than 10th centile. With or without abnormal Doppler, it's here in this group, in the high risk group. In the current pregnancy, not the previous one. Single umbilical artery Doppler if it is detected. This is also high risk of small for gestational age. Okay, guys? So what is this orange group? Okay, so the orange group is not the 3rd group in the risk factor, it's a special group. Okay, so I will give her the name group S, special. What is the group S? The group S is a woman is unsuitable for monitoring of the growth by the Simpson's fundal height. She is in general low risk, but she's obese, for example, or she had congenital uterine malformation. So we consider this woman for follow up by the scan. Okay, so that's why I told this is S group. Okay, guys, is it clear so far? Group 1, group 2, group 3, and the special group S group. This is what we have so far in this algorithm. Can we have a look for the follow up? What shall I do for each lady after the risk assessment? Yes, please. Okay, so have a look. Moderate risk factor or low risk factor or high risk factor. Which one to start with? Of course, it's the low risk. If we have no risk factors, okay, guys, if you do have comments, please write it down, okay, and we will discuss it at the end, please, okay? So, no risk factor in a low risk individual, so anomaly scan will be done normally because every pregnant woman in the UK will have anomaly scan, and the estimated fetal weight will be checked. If it is okay, so we will advise serial measurement of the symphysis fundal height for this lady, right? It's fine? Are we happy so far? So the lady will have the symphysis fundal height, and when we do the symphysis fundal height, this will be in the 3rd trimester, okay? And it will be like 2 weekly interval, and if you find that there is discordance in the measurement, okay, like a midwife, she found that the lady have inappropriate growth, okay, less than expected, okay, so she will send her for scan. That's it, okay? So this is for the low risk group. How about moderate risk group? Moderate risk group, my dear friends, it's a case with risk of late onset FGR, late onset FGR. That's why the surveillance for this case start a bit late, okay? So if this lady, okay, assessed her history of placental dysfunction, and we can consider prescribing aspirin according to her risk for preeclampsia, okay? And we will check at least one of symphysis fundal height measurement at the 28 weeks, okay? And everything is fine. Anomaly scan was fine. Estimated fetal weight is fine. Serial ultrasound from 32 weeks, every 4 weeks until delivery. Happy so far, my friends? Moderate risk. We'll just have the follow-up as usual. Anomaly scan as usual for everyone. And if it is okay, then what will be the next time to see her? This will be from 32 weeks, every 4 weeks until delivery. Okay, fine? Fine. How about high-risk individuals? High-risk individuals, they will have assessment, okay? We can advise for them aspirin, of course, right? And we will advise the screening by the uterine artery Doppler. When to do the screening by the uterine artery Doppler? It's from 18 to 23 plus 6 before 24 weeks. Okay? So from 18 to before 24. And again, the conditions, what is the possibility of this uterine artery Doppler screening? It's either 1 or 2 or 3 or 4, right? So let's see what if. Normal uterine artery, normal weight, normal. What is the advice for follow-up? Thank you very much. You are fine. See you at the 32 weeks, every 2 to 4 weeks until delivery. Right? Correct? Okay. Then, condition number 2. It's normal uterine artery, but baby is small, less than 10 centile. So what shall I do here? Serial ultrasound from 26 to 28 plus 6. Okay, for some reason it has the dollar mark anyway, until delivery. So baby is small, so I will start my serial ultrasound assessment starting early from 26 to 28, okay, until delivery, right? Good. Condition number 3 says abnormal uterine artery Doppler and estimated fetal weight 10th centile or more. So abnormal Doppler but normal growth. Still this baby at risk. So thank you very much. I'll need to keep an eye on you starting from 28 weeks, every 2 to 4 weeks until delivery. Okay, can I call this baby fetal growth restriction? No, it's not, but I am following because of the abnormal Doppler. Okay, guys, this is the condition number 3. How about condition number 4? And the condition number 4 says abnormal uterine artery Doppler and abnormal weight, abnormal, both are not good. So what shall I do? Actually, I need to discuss with the fetal medicine, especially if this is discovered very early, right? Like at the anomaly scan or at the 23+6, okay? So it will be discussion with the fetal medicine. But when to start the serial ultrasound assessment? Do you remember? Page 21 from the guideline says from 24 to 28, starting from the 24, okay, until the delivery. Clear, my friends? What form of ultrasound then? What form of follow-up? What form of follow-up? I found now a case of small-for-gestational age. No. Fetal growth restriction, even with abnormal Doppler. So once I have abnormal Doppler, okay, and I have to check here, okay, this is the umbilical artery Doppler, okay, yes. So if I have absent or in diastolic flow or reversed in diastolic in the umbilical artery Doppler, because the umbilical artery Doppler is the one for the follow-up, okay, I will monitor minimum twice the week with computerized CTG and or ductus venosus. What if a case of fetal growth restriction have normal umbilical artery Doppler? If she had normal umbilical artery Doppler, then the follow-up is not that much tight. I will see her every week to check for the umbilical artery, right? Weekly, okay? And estimated fetal weight should be repeated fortnightly, not less than 2 weeks interval, okay? So estimated fetal weight will be every 2 weeks. Remember, again, if everything is fine, everything is all right, the follow-up with the umbilical artery Doppler in fetal growth restriction babies or small babies, right? And if the umbilical artery Doppler is abnormal, if show abnormality, I will be here and I will advise minimum of twice weekly computerized CTG and or ductus venosus, right? So this is the plan. And again, my friends, what we used to say is use the algorithm, okay, as a mind map, right? So better understanding and application of the algorithm, this is a required training. It's a skill which requires training. If you have it well arranged in your mind, okay, you will never miss a question in this part, right? So what you need to do? You need to do is revise again and again. You can even divide it into small pieces for revision, okay? I'll tell you a secret, okay? When we have a preparatory meeting, like it's a meeting, for example, between instructors or tutors, I had a meeting with Dr. Nada before, before the writing the notes and all, okay? Once this guideline is released, we arranged a meeting and we discussed together about how to approach this in teaching, okay? What is the new information? Then after what is the new information, how to make it simple and easy for the candidates, okay? So we agreed that we will subdivide this, okay? And we are going to make it like 3 different parts or 3 different slides, okay? So we will explain to the candidate that what they have done here in this algorithm, that they give you the first part of it, the early fetal growth restriction babies. And here is the late, right, in the second part of it. And here is a term, which is the least risky group, right? So guys, in your approach, just try to understand what is the situation, what shall I do when I read the case and apply it on the algorithm, okay? How to navigate through, okay? So now I have a case of early FGR, which is an important definition also in this guideline. So the early FGR, when the fetal growth restriction is diagnosed or discovered before the 32 weeks. Do you think this is a favorable outcome or not? Is that a good thing? Have a fetal growth restriction very early? No, of course it's not. Why? Because that's mean you will have a close surveillance, and once you get a critical level of the abnormal of the Doppler, or you got abnormal CTG, you will go for delivery, and this delivery will be early. So you have now combined problem for this baby, right? So this is the group that you need to take carefully, okay? And here they tell you if the fetal growth restriction, if discovered very early, okay, at the 24 to 25 plus 6, you have to, okay, take like individualized care plan for each case. If it is diagnosed from 26 to 28 plus 6, we are following the same advice for follow-up and the same everything. But I would deliver if the ductus venosus found to have a wave is absent, or the STV, okay, is less than 2.6, okay? Right? Okay, so here, if the small for gestational age discovered at 29 up to 31 plus 6, I'm following the same follow-up, but I will take the decision for the delivery if the ductus venosus A wave is absent, or the STV now is becoming less than 3. Okay? So here also is for 32 to 33 plus 6, which is still valid to follow them up with the ductus venosus. Decision for delivery will be when the ductus venosus A wave is absent, or the STV is less than 3.5. Okay, so guys, try to remember when is the indication for delivery, when to say this is for delivery, okay? When you have acute condition like ductus venosus A wave is absent, or the STV, okay, let then the value corresponding to each gestational age, okay? If you have a repeated deceleration on the computerized CTG, or if you have any other indication for delivery, then you can consider delivery earlier than this. But when is the recommended delivery plan for early detected FGR? Early detected FGR, when to deliver them? That's a very important question. Deliver them, okay, by 34 weeks if absent end-diastolic flow in the umbilical artery Doppler, okay? And sometimes I can consider from 32 if there is other indication. Consideration for delivery in case of reversed end-diastolic flow will be from what time? From 32 weeks. So the early FGR can have 32 weeks or 34 weeks according to the umbilical artery, but I can deliver them acutely if I have a problem like ductus venosus or abnormal CTG. Okay, guys? So those are the indications and the timing for the delivery. How about late onset FGR? I discovered a baby small for gestational age or even severe, and it found to be FGR, okay? After the 32 weeks and before 37, I call it late FGR. I will follow up weekly, okay, by the umbilical artery Doppler, and 2 weekly I will do the fetal weight, okay? If the umbilical artery Doppler found to be abnormal, remember twice weekly CTG. And remember, after 34 weeks, no rule for ductus venosus. And I will deliver if the STV is less than 4.5 or absent in diastolic flow. Okay, so dear friends, when is the recommended time of delivery for this group? You will deliver by 36 to 36 plus 6, okay? If the PI more than 95 centile in the umbilical artery Doppler, right? How about if I have a small baby, okay? Only small baby, only small for gestational age, mean that less than 10 centile and not less than the third, and normal Doppler. When to deliver this baby? There is no indication for early delivery before 39 weeks, okay? If everything is okay, just the baby is small, and the delivery will be considered from 39 and be completed by 39 plus 6. How about if I have baby less than third centile? Okay, baby less than third centile, diagnosed at term already, like at 37 weeks. When is the time for delivery? I found that the baby is very small. It's FGR, less than third centile. When to deliver? It's by 37 plus 6, okay? So before even completed 38. So my friends, what do I understand from here? What do I understand from here? That the decision for the surveillance, okay, will be based on the umbilical artery Doppler value. If it is abnormal in the early FGR, then we have to increase the surveillance to minimum twice per week with the computerized CTG and or ductus venosus, right? And according to the values, okay, or abnormality, if it is detected in this particular critical gestational age, okay, so I will deliver. Otherwise, my plan for the delivery will be by the 34 weeks in the absent end-diastolic flow, and by 32 weeks if it's reversed end-diastolic flow. In late onset FGR, okay, if the umbilical artery show that the PI, the versatility index, is more than 95 centile, so I will deliver between 36 to 36 plus 6. If I have a baby diagnosed at term already, early term at 37, okay, diagnosed with FGR, so deliver and not beyond the 37 plus 6. If I have only small for gestational age, a small baby, less than 10 centile, and everything is okay, so wait till 39 to 39 plus 6. Okay, friends? I hope it's clear so far, and I hope that I have tried to help, okay, with the explanation of the algorithm. But as you have seen and experienced today, that the questions, it's all what matters, okay? So when you solve the question and you understand the situation and you locate it on the algorithm, okay, then you are only sure that you have the clear concept and you can do it by yourself in the exam. Right, my friends? I hope that this was useful. Yeah, so Dr. Laila Madir, the question is asking about the mode of the delivery. If you have preterm with abnormal Doppler, go for cesarean section. Okay? Full term and small size, okay, so you can try for normal vaginal delivery. Right? I hope it's clear. Okay, thank you very much, guys.